become more financially sustainable and profitable. From my experience with handling different sessions of our health financial models program that we've done for different hospitals, is always a key thing, because most times hospitals are set up with very good intentions to save lives. Doctors are very passionate about their jobs, but then when it comes to the whole financial sustainability and how profitable the business is, the issue of measurement and accounting is a challenge. So this idea of having better outcomes and being profitable is not an overambitious idea. Across the world, healthcare systems are shifting from volume to value. So people are not just paying for services delivered, but for results achieved. And though the Nigeria context is unique, I mean, we understand ourselves, but the opportunity is real. So this whole discussion about value-based care is a good opportunity for us in spite of our unique context. So in this session, we are going to unpack exactly how Nigerian hospitals like yours can make that shift without compromising your bottom line. We'll explore practical models and reward outcomes. We'll discuss risk sharing mechanisms like capitation, performance-based bonuses, and also look at examples of how others have done it profitably. So whether you're running a very big specialist hospital in maybe Lagos or Abuja, or a mission-driven hospital in Enugu, Aba, or any part of Nigeria, this session is designed with your operational reality in mind, and local payment structures, staffing constraints, and balancing act between clinical excellence and financial viability. So, but more than just insight, today is also about action, which is what I always preach each time I have this kind of opportunity. We need to take action. So when we learn about these things, what are we going to be doing differently? So we'll be introducing you to financial literacy tools and strategies that you need to succeed in a value-based world. So it's not just about learning, it's about transforming your hospital into a high-performing, patient-centered enterprise. So please, I encourage you to engage fully, ask questions, take notes, picture what this could mean for your hospital, because in the end, our shared goal is simple, and it's urgent. We need to make quality healthcare more accessible, more affordable, and more sustainable across Nigeria. So thank you once again for joining, and we'll get started in a bit. You're all welcome. Now, at this point, I don't know, can I share my screen now from my end?
Yes, you can. Please go ahead.
Okay, thank you.
Yeah, Kelechi, we can see your screen now.
Oh, thank you very much. So I was just going to ask. Okay. All right, so these are our roadmap. We'll be looking at global healthcare landscape, Africa and Nigeria healthcare landscape. Then we'll dive into value-based care, which is our topic for today. Looking at the key concepts and core principles. Then we move to the case for VBHC in Nigeria. So VBHC basically is value-based healthcare, and the economic basis and steps to transition. Then look at the key challenges, opportunities, and of course, we'll have time to ask ourselves different questions. I'm having double screen, so in case I'm not looking straight, I could be looking at the other screen. All right, let's get it started. So the global landscape. The healthcare landscape is evolving. We are moving from volume-based care, which is same as fee for service, to value-based care models. This transformation prioritizes patient outcome, efficiency, and cost effectiveness over service quality. Now, don't get me wrong, because I mean, we are very much interested in the quality of service. But what we are saying is that under value-based care, we are focusing on patient outcomes because over the years, the way medical service has been rendered, there's a lot of data around quality of service, measuring quality, a lot of checklists, a lot of standards, a lot of work around quality healthcare. But we don't have that much on outcome, like who is measuring the outcome for the patient, who is measuring that this treatment was successful to the way the patients want it, not to what we feel is okay. So that's what this is really about. We are moving to that level. And in Africa, where healthcare financing is often constrained, this transition holds promise because, but also presents unique challenges. Like I mentioned earlier, our landscape, a lot of challenges, and we need to just find a way to work around them and improve things. So health leaders, providers, policymakers need to understand the economic implications of this to ensure that we have this shift and make it very impactful and sustainable. At this point, I would like us to watch a video, a documentary around a clinic in America that is focused on this value-based care. So you'll just have a bit of more clearer understanding of what it could look like and what is obtainable. So just take some time to go through this video. Paul, please take over and play the video. Thank you. So let's pay attention and observe what the keywords are.
Hi, how are you? I'm here to see Dr. Sam.
At age 77, retired beauty salon owner Helen Durham has battled a range of illnesses, from high blood pressure and high cholesterol to a potentially life-threatening blood clot.
Right in here.
Okay.
On this day, Durham has come to the Richmond, Virginia Clinic of GenCare, a division of ChenMed. She's meeting with her longtime physician, Dr. Shruti Sambamurthy, who's also known by her patients as Dr. Sam.
Hi, Mr. How are you doing? So good to see you. Oh my gosh, 30 days, huh?
Durham has been a patient at this clinic for 11 years and a patient of Dr. Sam's for the past 6. It's not just physical ailments that the doctors help Durham with, but also emotional issues, including the recent death of her adult son from complications of diabetes.
She has needed frequent visits over the past couple of years just to really help her cope with the grieving process, especially losing her son. Unfortunately, during those times, she also ended up having health conditions because of that.
Make sure that we're mentally happy.
You're right. Dr. Sam could see me slipping mentally. So I would go to my regular visits, and she would look at me and she would say, Miss Durham, are you okay? And she said, no, you're not. She's not a psychiatrist or a psychologist, but she seemed like one to me. That was the lifeline I needed, because right before my son died, my sister, I had just lost my only sister, and then my mom before her. So that was just, I was at my wit's end. And if it wasn't for her, I don't know how I would have gotten through it.
These close connections between doctors and patients are par for the course at GenCare, where most of the patients are older adults enrolled in Medicare Advantage plans. They benefit from a holistic care model that takes full accountability of their care, its costs, its quality, and their overall health.
We're talking about seniors that are living under conditions where they're not able to just take care of themselves, never mind their complex medical conditions. And I think instead of really focusing on the reactive approach of medicine, what we're trying to do is the proactive approach of medicine, where you're able to prevent medical conditions from happening. So that way you're really reducing catastrophic events in patients' lives.
The approach is sometimes called value-based healthcare. And to patients like Helen Durham, it's precious.
Oh, okay.
Right.
That's where the pain is, the stiffness is coming from.
Exactly.
It's invaluable. I don't think you can put a price on it because it's something that in my 77 years I've never seen, and I've had some of the best doctors living in Washington, D.C. I've never seen this level of detail and this level of attention to patients, kindness, attentiveness, going that extra yard, the extra mile to make you feel like you're important. That's what we need. And I think they need more of these type of centers.
There are other key features of this care model as well, says GenCare's Regional Chief Clinical Officer, Stephen Lewis.
The care that you can provide in a value-based setting is, it gives you the ability to build a relationship with your patients. We're much more available to our patients. And I think that the accountability piece is really important in value-based care.
The financial arrangements underlying the model make this accountability and these closer relationships possible, Dr. Lewis says. They're different from the most common arrangements in U.S. healthcare. Doctors are usually paid on a fee-for-service basis for each visit or procedure in most common insurance arrangements, or by the Centers for Medicare and Medicaid Services, known as CMS, which handles payments to providers under the traditional Medicare program. By contrast, Dr. Lewis explains, practices like GenCare's are paid very differently under arrangements like Medicare Advantage.
We are full risk value-based care, which means that we get paid on a monthly basis to care for our patients. And it basically, we look at the risk of our patients, and the CMS and the insurance companies tell us, okay, this is how much it should cost for care for those patients. And so if we're able to provide them great care, we're able to keep them out of needing to go to the hospitals and emergency departments all the time, then we're able to do well. And so what that monthly payment does is it allows us to be able to have smaller panels. So our doctors here carry 450 patients. We are able to see our patients more often because we have a smaller panel. Most fee-for-service doctors may carry thousands, 2,000 to 5,000 patients, depending on where they work. And so we carry smaller panels. We have a closer relationship. We see our patients monthly. That's our goal. Though sometimes if they're sick, we will see them more often. Our sicker patients, we will see twice a month. And so being able to receive that monthly payment for our patients in a value-based setting directly leads to us being able to provide closer care, better care for the patients that we have.
The financial underpinnings of the model also enable its other key aspect. Coordinated care for patients like Daphne Dudley, who's disabled and has health coverage from both Medicare and Medicaid.
All right, take your time to step down, step down.
Ms. Dudley is a 59-year-old. She has a history of Crohn's disease and ulcerative colitis, which is inflammation in her bowel. She's also pre-diabetic, has had some elevated blood pressures before as well. So the biggest thing is really for patients like Ms. Dudley and a lot of our patients is the actual coordination of the care that they're receiving. Oftentimes, in primary care, our patients, and particularly if they're complex, are seeing a lot of specialists. And so having that understanding of what's happening with all the specialists, kind of being the quarterback of what's happening with them and letting them know the indications of different procedures and why they should or should not do certain things is really helpful. And so a lot of the time what we're doing is explaining the care that they're receiving and kind of helping them navigate and understand what all the different specialists that they're working with are recommending and why. If you're having stomach upset, it's important that you let us know.
Patient Daphne Dudley says that coordination of care with GenCare's physicians like Dr. Lewis extends to financial matters as well.
Most people, they worried about bills, how to pay bills. A lot of people don't go to hospitals and facilities because they're worried about a bill, paying a copay, none of that. He makes sure that, hey, before I do this, I'm going to get my coordinators to call your insurance.
Still, other aspects of GenCare's value-based care are as appealing to doctors as to patients, says Dr. Sam.
I became a clinician because I wanted to deliver good outcomes to my seniors. I want to practice in a place where I can actually practice medicine for the reason I went into practice medicine, that is take care of people. This is what human beings do. And a model like this is a perfect platform to do that.
That includes having some specialists, like cardiologist Preeti Dubey, practicing right on site and able to consult frequently with many of the clinic's patients.
When we see our patients who are above 65 years of age, majority of them have certain congestive heart failure, whether they have blockages in the heart, some kind of heart conditions. How do we prevent them from getting further sick? How do we manage the conditions that they currently have from worsening, from progressing to the point where they might need ER visits or hospitalization? So it's a close collaboration where the center of focus is our patients.
Having this broad care team in place is another strength of the value-based model. That includes having a nurse on hand after normal business hours to take urgent calls from patients and even dispatch paramedics to their homes if needed.
But they can go give medicines, they can evaluate the patient. We triage to figure out what's going on with them. And if they need to go to the hospital, then we will call the hospital, basically making sure that the emergency department docs and the hospital docs have all the information that they need to care for the patient.
And even when GenCare's patients are hospitalized, the close connections don't stop. Dr. Paula Palomino was until recently GenCare's regional medical director.
I lead a fantastic group of social workers, nurses, coordinators, and what we do is we talk to each other. We have these morning daily meetings with the center medical directors of every center, and we talk about what is going on with their patients. What is the discharge disposition, meaning is the patient ready to maybe leave the hospital in 1 or 2 days? Is this patient going home? Is this patient going to rehab? Will the patient need any help with any device or any medication? So we try to make sure that that patient is going to be discharged in a safe way, so that way we prevent readmissions and we make sure that that patient can go back to their PCP, which is the primary care provider.
Follow-up care continues when the patient is home, said Dr. Palomino.
Our social worker will make a phone call to see if the patient has any problems with shelter or any economical difficulties. We can do home visits. We can see if the patient has any support at home, because everything that we do here is preventive.
It's the very essence of the value-based care model.
The secret sauce is the trust that you develop through relationships with your patients. So you get the time to know who they are, their backgrounds, their history, not just their medical concerns, but also we take it personal. We get connected to an emotional level, and we really care for the patient as a whole, not just, oh, you have diabetes and you need medications. We also care about when was the last time you talked to your son? You know, when was the last time your daughter visited you? Do you have relationships with your grandkids? So we want to know, because we understand that it's not just about the physical health, it's your mental health. It's making sure that our elderly population has that social life that will keep them healthy. So it's the trust that we develop with our patients. They trust us to care for them, and we trust them to follow the recommendations that we provide to them.
Relationships, trust, accountability, teamwork, prevention, and coordination are all at the very heart of value-based care.
And if you need anything, text me, okay?
Okay, I have your number. I'll text you.
It was truly a pleasure to see you as always.
Well, Doc, you know what? You're one of the bright lights in my life, so thank you for keeping me healthy and for always knowing when I did not take my medicine.
Right.
Thank you very much. Thank you very much and welcome back. And for those who joined us during the video, you're welcome to this session. Just pay attention, take note of your questions, and let's make it as interactive as possible so that we'll share what we are learning as we go along. So I'll go back to sharing my screen. Just take any point you noted from that video during the discussion session. But one thing is clear: trust. I mean, that trust has to be there. That's one of the things that's one of the fallout of value-based care. Okay, hold on. So we are going to be moving on to understand how this value-based care works. Okay. to get this out of the way. All right. So how it works, comparing traditional method, which most of us are used to, which is like the old way of doing things, and how we are hoping to start doing things going forward. For the fee for service, we have one, you pay per service or per procedure, while on the other hand, for value-based care, you're paying for outcome and results. The incentive on the fee for service is volume. Incentive on value-based care is quality. Then you have fragmented care under the traditional service, but for the value-based care, it's coordinated. It's team-based care. The people that are going to do the lab test, the ones doing the MRI radiography, everybody understands, the consultant, the surgeon, everybody that is needed, the nurses, everyone that is needed for that care to happen are well coordinated and organized. Then we have for the fee for service, no links to results, but of course for value-based care is tied to performance and improvement. Okay, so let's look at the core principles of value-based care. One, cost effectiveness. Rewards efficiency and effectiveness over quantity or procedures. When we start looking at the strategies involved, you understand why it is cost effective, because you're paid for value, you're paid for results. So you're going to make sure to deliver that service in the most efficient way, and that results into cost effectiveness. It's patient-centered. Of course, the focus is on improving individual patient outcomes and experiences. The patients should be treated in a way that they feel cared for, not necessarily because we are ticking checklists. No, the patients need to feel that they are at the center of this whole thing. The accountability, it providers are responsible for delivering measurable results and improvement in health. So the results must be measurable. And of course, we'll talk about data as we go along. Then talking about coordinated care, encourages collaboration across care continuum, the primary care, the specialists, the social services, everybody in the chain of giving that care is involved in the whole process. So now let's look at our state of healthcare in Nigeria. Currently, we are over-relying on fee-for-service model, which leads to inefficiencies, lack of accessibility and poor quality of care. We have rising burden of non-communicable diseases, and we have limited healthcare financing. The case for value-based healthcare in Nigeria is huge, because first of all, value-based care will address inefficiencies and improve outcomes at lower costs, and shift our focus to prevention, early intervention, and managing chronic diseases better. And we also have global case studies to show the effectiveness of value-based healthcare. Now, even within Nigeria, let's talk about the silent profit killers in many Nigerian homes. In many Nigerian homes. Sorry about that, guys. So one, there are many areas where money is leaking every single day when it comes to the way we manage our healthcare services. Is it the issue of duplicate lab tests? Sometimes we are conducting tests that have already been done, but because it wasn't properly documented, or lack of coordination, and we just incur unnecessary costs in the process. And sometimes we're also annoying the patients, and they're feeling like, I've done this, like you just want to keep drawing blood and all of that. I talk about readmissions. Every time a patient returns because of complications or a poor follow-up, right? It will cost the hospital more money. And under the value-based care, this is even more critical, because you're not trying to manage, because you're paid for outcomes. You're being more careful for prevention to avoid those cases of having people being rushed to the emergency room. Another area of leakage or waste is medication. The way we manage our pharmacies, a lot of waste, either from over prescription, improper storage, inventory control. Sometimes you have a whole, like you see, cartons of medications have expired and are going to be thrown away because somebody has overstocked, and we're not managing the stock let's say stock count now or stock control in general. So, and beyond these three examples I've mentioned, there are other areas like long hospital stays, like when outpatients, somebody is already something that could just 3 days and then you manage from home, but we're having people overstay in the hospital, and we're having poor documentation, billing errors. Let's not even get into the issue with HMOs and all that. So these are just a lot of issues that affect the profit margin, that makes the whole hospital business not as profitable as it should be. Because really, when we talk about value-based care and saying that it's profitable, profitability does not only mean that you're going to have to cut corners. You can actually give value care and still make profit. And remember, in value-based care, what you don't manage will cost you a lot. Yeah. Now let's also go into the value-based care economics, like what's the basis of transitioning to value-based care. One is rising healthcare costs, inefficiencies and waste, and population health imperative. For the rising healthcare cost, traditional fee-for-service models encourage high volumes of tests, procedures, and hospitalizations, which end up driving up costs without improving outcomes. Then we're looking at inefficiencies and waste because of the whole fragmented care that leads to fragmented, like duplication, medical errors, avoidable readmissions, and burdening both the providers and the patients at the end of the day. Population health imperatives about value-based care to enable preventive care and long-term condition management, improving health outcomes for communities at lower cost. Also, still on the economics or the value for this, we are looking at aligning incentives and sustainable financing. So aligning incentives that the value-based care links provider payment to performance, which encourages better care delivery and responsible resource use. Because if you notice, one thing keeps coming up, proper resource management, reduce waste. At the same time, you're getting more value and you're able to stay profitable. Then sustainable financing, because it supports the long-term financial viability of health systems, especially in low resource settings like many African countries. We don't even have the budget for healthcare is not even enough to take care of the population. So the little resources we have, it would be good to just maximize it, and it benefits both the healthcare practitioners and the public at large. Now, what are the cost savings opportunities that this value-based healthcare can, give to us? One, we are looking at preventive and proactive care, because early intervention will reduce complications and the need for expensive emergency treatment. One of those conditions would be like the issue of diabetes. Diabetes can be managed and not going to be as expensive if everything is monitored, the HbA1c is monitored, the person's kidney function is monitored, eye checks is done, routine, everything is planned around the patient, not waiting for them to show up with one complication before we begin to take necessary steps. So preventive and proactive care, very, very effective for cost saving. Technology and digital health tools. We could be using telemedicine, mobile health apps, and remote monitoring could reduce physical visits, which improves efficiency, because physical visit to hospital has its own cost. Don't forget, this whole cost savings is both on the side. It's like looking at the total, what it will cost in total to take care of a patient. And you have to consider that it's going to cost patients money to transport themselves to the hospital as well. It's going to cost you more to maintain the facilities at the hospital, the toilets facility, and all the other public facilities in the hospital. If you have so many people coming in and out of the hospitals that could have been attended to online. We're looking at integrated coordinated care, also encouraging teamwork among providers to reduce duplication and errors. Then we have streamlined administrative processes. These are all cost-saving opportunities when you're considering value-based care, because you're going to have simplified billing, digital health records, and claims management to reduce overhead costs. Just imagine where, when we start talking about the strategies and the different models, you're going to be seeing that when you begin to bill as a bundle, it simplifies the billing process. You don't have to bill by, oh, we had sample blood sugar test was done, then the 2 hours post-random was done, and then 3 months later we did the HbA1c, then we administered metformin and all of that, which goes on with managing diabetes, for instance. You're going to be having a bundle pack that says the monthly cost of managing a diabetic patient based on the risk level, of course, is you put a cap to it, which streamlines. So every month the bill just goes to either the HMO or the organization or the patient, that this is the bill for all the care that they did for that month. Whether they came in under emergency, whether they came in 2 times or once, the important thing is that they are healthy. So at that, you see that it's simplified billing, digital health records, everything, claims management, overall um, overhead cost is reduced. Then tax shifting and team-based applications are another way of managing cost. You can train nurses, community health workers to manage routine checkups. Everything must not be handled by a doctor, because the cost per hour of a doctor's time is way higher than that of a trained community health worker, for instance. So we need to learn to use tax shifting and build trust, because another thing is people need to trust that that health worker, who is not a doctor, understands exactly what needs to be done at that point for them, and understand they don't even need to see a doctor at that point. So these are a lot of cost saving opportunities. So which also translates to reduced avoidable hospital admissions, lower treatment costs through prevention, improved workforce productivity to healthier population, and then greater donor and investor confidence in transparent, result-driven system. So we're going to be looking at moving to designing a profitable, value-based care system. So we're going to spend some little time here to take us through each of them, because while we're talking about value-based care models, there are a lot of ways to look at it. The first one I'm going to look at is bundled payment. I already mentioned it a little in my previous slide. So here, a single payment is made for all services that relates to a treatment or a condition over a defined time. Like you can say, okay, for maternity care, surgery, rehab, and I already gave an example with diabetes. So how it works is the hospital will receive, let's say, 150K for everything from antenatal to postnatal care. Of course, this I'm just calling an amount. Don't take it seriously. I know that medical care is really expensive now. So just make sure that you have the total cost of what it will take to handle a pregnant mother from antenatal to postnatal care. That way, they don't have to worry about, oh, I have to pay for my medication, I have to pay for this particular scan, or should I do this scan or no? That's where people begin to, let's assume that they need a standard of, let's say, 3 scans. People could, because of payment, decide to not come for the third one or do only 2. But if it's already a bundle package where everything has been costed, the patient gets value, because that means everything that they need has already been accounted for, and they will just go in and receive the service without having to worry themselves about, oh, can I save some money by not going for this extra antenatal care appointment? Now, the way it works is if you spend less while maintaining quality, then it's profit. So because it's value driven, you have a bulk charge, let me say 1 million naira, but at the end of the day, some mothers will cost you more, some could cost less. Now, depending on how you have managed, if you've made sure to follow up with them on all the antenatal visits, call them a day before the antenatal or send messages to remind them, make sure that they come in for the antenatal care, make sure that all the necessary scans are done, make sure that they're taking their medication, educate them, because you have to build that relationship, educate them. Remember your target is value. You're not just trying to tick boxes. You want to make sure that whatever you're doing is actually working. So you're going to be taking all of these steps to ensure that we have a very safe delivery. At the end of the day, we have healthy mother, healthy baby. And you've made and your payment is either you're billing from the HMO or the patient is the one paying. So if it is well managed, it's profitable. You keep the rest of the profit. But if it's a case where things were not properly managed and it had to lead to some kind of emergency, your profit may not be as high. So the more you are able to have that seamless process, the more profitable. The same thing for another example could be, so let's look at how to the profit strategy around this. You will need to standardize your clinical protocols, to reduce the variables. You're going to coordinate with your labs, your pharmacies, everybody that is involved to manage cost. And then you're going to try to avoid complications so I don't eat into your fixed bundle fee. Don't forget you already have a fixed fee. Now, a private medical, let's say a maternity center, if you're offering a bundle for child package, you're covering the scan, delivery, postnatal care. If you have a lot more success rate with smooth vaginal deliveries and you're not having complications that are leading to a lot of C-sections, it could boost the quality of care while also increasing your margin at the end of the day. So that's on the bundled payment. Capitation and performance bonus. So it's like two things. In some cases, it could just be only capitation and it could be performance bonus, but looking at the two of them at the same time. Now, capitation, what it means is that so in this case, now you have a fixed monthly payment per patient. So it's like per patient per head, there's a controlled cost. Now the provider receives a fixed monthly payment for each patient, and it covers the agreed scope of services, primary care, checkups, labs, and etc. At the end of the period, it could be quarterly, monthly. For the performance bonus aspect of it, your performance will be assessed. What will be the key KPIs? We can look at, okay, you have a certain percentage of hypertensive patients with controlled blood pressure, a certain percentage of diabetic patients attending your follow-up clinics and their HbA1c is not beyond a certain level. You have my maternal and child care outcome. Okay, how many successful deliveries? And then apart from the capitation amount that has been placed per patient based on the different kind of categories of care, you receive an extra bonus for performance for meeting those KPIs. So you see that it's no longer just a matter of, okay, how many patients and then just get the payment. And another thing is that another way to make it work very well is segment your patients so that you have for those that are high risk, low risk. Then you can also use tax shifting to reduce costs. You can track and document everything, ensure you have a proper EMR, that's electronic medical record system, to prove performance. Because for you to claim those bonuses, I mean, you're going to show records, right? Then you have to negotiate smart KPIs. In all of this, one thing I can tell you for sure is that to run a successful value-based care in your facility, records, data, financial records is a must because that's the basis. Now, let's say a hospital contracts HMO to manage 1,000 enrollees under the capitation and performance models. You can look at the capitation fee of maybe 100K per patient, and then there's an additional bonus to say if 80% of the diabetic patients have HbA1c of less than maybe 7% at the end of the year, the hospital will get extra 1 million. So you see that at this point, you're making sure that your nurses, your community health workers, everybody is following up on the patients to be sure that they are actually taking their medication, coming for their test, and all of that. It's something that we need to really, really imbibe. So from my own experience here in the UK, you will get sometimes I get calls, I get letters, I get follow-ups, and I'll be wondering who sent them. Like, did I complain? But so I am a person living with diabetes. Now, because I have to, even before I left, when I was in Nigeria, I had my doctors, I was going for my appointments, but I was never, if I missed my appointment, nobody was calling me to say, oh, you're due for the 6 months check or you're due for the 3 months check, because you're going to be expected to like take responsibility and come to the hospital either way. But if you're looking at basing this care around the patient, you see that you're going to be making sure that because your outcome, don't forget you have bonuses attached to outcomes. You have payments based on the outcome. So you see that you are focusing on the patient and it's still profitable for your business because you're not having to deal with complications of diabetes. You're not having to deal with emergency surgeries, heart attacks for people with high blood pressure. Another, going to the next one, which is the shared savings model. So here, hospitals and providers are rewarded for reducing healthcare costs for a defined population. So while maintaining or improving quality, we are looking at if you are able to save a certain amount of money, then you share the difference between you and, in this case, this can only work with HMO or an organization like where the payment is coming from a structured body. You can actually share that difference and say, okay, you keep 50-50 of whatever is the extra, because the budget for caring for, let's say, 1,000 enrollees for high blood pressure was, let's say, 10 million, and you've managed to do that within the cost of 8 million, and the remaining 2 million can be shared. That's an extra 1 million for you. So again, we have to make sure that we coordinate and document all the care activities. And looking at the Nigeria context, really, I would just say keeping in all of this, keeping our records is very, very key because that's the only way it can be to measured, right? Then another one, patient segmentation and risk stratification. These are under data-driven approach and categorizing your patients based on their health risk, tailor it to the interventions that they need. You have to group them low, medium, high risk categories. You can group them by age, by chronic diseases, by, history, past admissions, what has happened with this patient. So overall, your strategy is to reduce the cost by focusing expensive resources only on patients that actually need them, right? And then apply for bundled payments or capitation contracts based on the risk level. So these are the kind of things that will help you negotiate better when you're dealing with your for those who are going to make the payment at the end of the day. So everything at the end of the day is really based on how you are able to manage your contracts, manage your data, and ensure that you're profitable. And profitability will always give them, plus better outcome will always be that's what we are aiming for. Okay. So that's that on the care models that we can, explore. Now, I have said a lot of things, and you begin to ask, I'm not an accountant. How am I supposed to track all of this? So as hostel owners and managers, we don't expect you don't need to become an accountant. Um, sorry, this thing is hanging. I need to admit. Sorry, excuse me. Um, please confirm you can see my screen.
Yes, we can see your screen.
All right, thank you. Let me manage my video. So what you should track really, as hospital owners and managers, you don't need to be accountants, like I said, but you must keep track of the right things to make smart business discussions under the value-based care, because wrong costing could make you unprofitable. And once you sign off this contract, it could take maybe another 12 months before you can renew or come back to the table to recalculate. So it's good to, check. So one of the things you need to measure is cost per patient episode. Now, this simply means understanding how much it costs to manage a single patient from start to finish. Include consultation, test, treatment, and up to discharge. If you can't measure it, you can't improve it. So you must have tools in place. Even a simple Excel sheet, you can start with that to track your cost per patient episodes before we can say, okay, on the average, this is what it costs us to take care of a hypertensive patient for 1 month, a diabetic patient for 1 month, and maternal care for 1 month, and all of that. Now, another thing to measure is or track is patient outcomes. For value-based care, rewards better outcomes and not more visits. So it's not necessarily where you're trying to send bill to the HMO to say, oh, this patient came on the 2nd, came on the 5th, came on the 6th. No, nobody cares about if they came 3 times, 4 times, or 2 times. The important thing is that they are well taken care of. So if you track things like reduced complications, faster recovery times, and fewer readmissions. So these tell you whether the care you're giving is actually working. And the third one to also measure is patient retention, because the competition is really stiff now, and patients talk. I mean, they talk to each other and they choose quality. So track how many patients return to you. Track how many ones came to you by referral, because a happy patient is your best marketing strategy, and value-based care creates more of them. Okay, now I'm going to look at some of the key challenges in transitioning. One, limited data and health information systems. I cannot even overemphasize this, especially in our climate. Inadequate infrastructure for collecting, analyzing, and sharing patient data. Thankfully, a lot of private hospitals and clinics, at least with my experience with some hospitals in Abuja, they already have a very fantastic electronic medical record for staff for patients. You could easily, get in. The doctor just logs in, sees what has happened with you, and able to update. Unlike what we have in some of our government and public facilities, and those are the ones like where you have the lot of population of people going to. So a lot of data is lost in the whole process. So it makes it difficult to measure outcomes, track costs, or justify payments. Two, provider resistance to change. Just like all of us on this call, like I said, it's not just about learning, it's a call to action. Are we going to take actions, or are we going to be resistant to change? So many healthcare providers are accustomed to fee-for-service models. Concerns about income loss, increased workload, or unfamiliar performance metrics could be what is hindering them from, embracing this. Another one could be weak regulatory and policy frameworks. Absence of national guidelines or incentives to support transition. Fragmented policies also slow down systemic adoption, because this thing has to be systemic. It's not something that will just be adopted in one area and not, across board. It has to be systemic. It has to go across board. And any facility that want to really begin to operate at the global standard, because that's where the whole world is, that's where the healthcare is headed, because people are trying to have more value, and you see that you're going to be having more efficient systems, not having doctors overworked because of people just feel you just need to be in the hospital all the time when a phone call could have just solved the problem. So another challenge could be financial risk for providers. So value-based care shifts risk to providers who may lack financial resilience to manage outcome-based contracts, especially challenging for small or rural health facilities. Because really, if we are going to be paid based on outcomes, some facilities don't even have the resources to stock up on the metformin that they need to administer to the diabetic patient before you talk about getting their pay at the end of the month or at the end of the quarter. So that's another challenge. Then you talk about lack of capacity and training, because there's limited knowledge of value-based care, the principles and all among health care workers and policymakers. So the more people are able, just like you are logged in on this webinar, is a way to have build your knowledge around this. It's a very vast topic. Is being in discussion for years now, and a lot of resources out there that you can also dig into to get more information and see how your facility can actually transition. So these are the kind of things that will help to close that gap in terms of capacity and training. Then health equity concerns. If not carefully implemented, value-based care may widen disparities. Providers might avoid high-risk patients. Remember, we are talking about categorizing your patients by different kinds of demographics. So it could mean that if it's not carefully implemented, it could mean that high-risk patients are avoided because people are trying to avoid anything that will cut their performance metrics. Those are the kind of challenges that we see in transitioning. But aside these challenges, we also have business opportunities, and that we'll be looking at next. There are business opportunities around value-based care. One is improved patient outcome, enhanced efficiency, sustainable financing, innovation and technology adoption, market differentiation for provider, and strengthened community trust, which I have mentioned some of them in the course of our discussions. But if you look at it, at the end of the day, we want a healthier society. We want our doctors to work efficiently. We don't want our doctors to be overstretched, especially with the current situation of things in Nigeria. We don't even have enough doctors. So it will be best that, in fact, doctors, right? Doctors, nurses, healthcare workers generally is limited resources in Nigeria right now. So we want to make sure that we are enhancing the efficiency of the use of these resources that we have. And of course, we're going to be strengthening trust while at it. So we're going to be looking at the steps to transition to, and also that, I have attracts results-based partnership, because there are donors out there, there are organizations out there that are ready to partner with you on results basis, because they also need those data for their own objectives. So if you're ready to show that your facility is able to track and show performance and show value for their investment, trust me, you're going to be having these partnerships, and you're going to be able to run your facility efficiently. And another thing that we must appreciate is that when you have this value-based care, with less emergencies, you have less unpaid bills, because you don't have patients who are coming in on emergency and then you're talking about payment, and payment is a problem because people must have planned out themselves. Payments are already paid on a monthly basis or on a quarterly basis. Now, steps to transition to value-based care. One, assess your current practices and readiness for value-based care. You need to check how ready are you. You have do you have the right tools to measure? Do you have the right tools to even know where you are at the moment? The number of patients that you have, how are you keeping your records? If you're asked, what is the revenue of your facility for the first quarter of 2025? Are you able to, do you have that report somewhere? Are your accountants keeping the record and sharing the necessary reports on a monthly basis? Those are the kind of things for you to be able to assess your current practices and readiness. You have to also develop your IT infrastructure for data collection and reporting, which I have mentioned over and over in the course of this discussion. Very key. Then another thing is you need to build partnerships with stakeholders. So your government, insurers, and providers. Then you're going to be looking at defining clear metrics for success. That's talking about the KPIs. We need to know what we are measuring, and it has to be reasonable. Then the fifth step is start with pilot programs. Like, you don't just dive into it, because let's be practical. How do you actually begin to shift to value-based care in your hospital without turning your operations upside down? All right. Start with one service line. Don't try to transform the whole hospital overnight. No, pick one area like maternity care, outpatient services, chronic disease management like diabetes, like high blood pressure. Focus your efforts there first. Is it manageable? That way you can manage it, is measurable, and it's less risky. Then another practical thing to do is to train your team, right? Train your doctors, your nurses, your admin staff. Everybody needs to understand the why behind this shift, because value-based care is a mindset shift. It's not just about changing how we bill. No. When your team gets it, they'll support the change. You need to also track your results. Begin measuring your key outcomes, patient recovery rate, time to discharge, readmission numbers, and satisfaction scores. In fact, I remember seeing will I call it customer now? No, patients feedback forms. Like you have these boxes in the hospital where they expect you to like drop your feedback. Were you treated right? Did you have a good experience? You know, those kind of things. At the end of the day, you collate it to get that's like a data to hear what your patients actually think of your service. So you need to track your results. Then you have to renegotiate your HMO terms. If you're going to be shifting from fee-based service for fee to value-based, you need to have that renegotiation and understand that terms with your HMO. So once you can show outcomes, approach your HMOs with the data, say, look, we've reduced readmissions, improved patient experience, we'd like to restructure our pricing or incentives accordingly. You'll be surprised how many HMOs are open to performance-based contracts. Then you have to also invest in data smartly. Like you don't have to spend millions, right, to get data. You have to just start budgeting for data to add it to your budget to start with. At least acknowledge that you need it. Then you begin to do better with patient tracking system. Data is really how you prove value, because even with the issue, with the example I gave of investors like donor organizations coming to partner with your facility, it's only with data that you can prove value and get paid for it. So hospitals that succeed in this transition are not necessarily like the biggest or the richest, but they are the ones that are start to, intentionally improve and consistently, improve their data gathering and interpretation. So begin from where you are, then build momentum and scale up from there. You don't have to go, all out. Start small, really. That's what I'm trying to say. So now let's look at some practical strategies for providers. Now, look at I think about 6 or 7 points. One is focus on preventive and primary care, coordinate multidisciplinary care teams, use data to drive decisions. I don't want to emphasize on the data again, I already said that, but you need to focus on preventive and primary care. You need to coordinate multidisciplinary care teams. The lab and the pharmacy and the nurses and the doctors need to be in sync, for us to, deliver value. Optimize patient engagements. Ask questions. How do you feel? A patient may prefer a different way of treatment or a different medication because there are options, right? Let your patients know the options that is available to them. Then redesign your clinical workflow for efficiency. You cannot have so consultation room is on first floor, and after the consultation, the patient needs to go for lab tests, and the lab test, the laboratory room where they need to draw their blood sample is in the third building in the compound. And when they go there to draw their blood sample, they have to come back to the building towards the gate. Like, structure it in a way that the patient don't have to, the workflow, everything should just be very efficient. Like, clockwork, save time and energy and patient experience as well. Then you have to align with payers and participate in value-based contracts. You have to align with your HMOs, align with organizations if you're offering services to organizations like maybe Shell or Chevron that, just pay for their staff medical care. You have to like really discuss and align with your payers. Then lastly, you have to start small, scale strategically. And bonus tip, build a culture of continuous improvement. Value-based care is not a one-time project. It's a mindset shift. Like I already mentioned, it's a mindset shift, and we need to begin to look at things from that angle, and they are actually very, very beneficial for us to work that way. Okay, so looking at risk management strategies, it could be risky. I mean, you're going into a new phase, a new way of billing, a new way of taking care of patients, a new way of keeping your records. So you need to look at the risk and manage it properly. If you don't have the skills within your facility, get a consultant to do that. Get it's not something. Risk management is a skill. Like, you have people who are professionals in these things. So you have to implement your risk adjustment mechanism, establish strong data governance and analytics, and diversify payment models. Then also share your risk. You maybe need to take up some kind of insurance. You need to take up some kind of risk transfer. Just make sure that it is properly analyzed, and you have a very effective strategy for managing your risk, right? So we're going to look at, we've talked about a lot of things in this whole discussion, and we're going to look at what are the key things if we're looking at this whole discussion, what are the key takeaways that we can take from it. One is that value-based care prioritizes outcomes over volumes. So it is not about how many times a patient visited the hospital. It's not about how many emergency situations were you able to tackle. It's not about the number of scans and the rest of it. No, is the outcome. At the end of the day, did we have a healthy mother and a healthy baby? At the end of the day, do we have a person living with diabetes whose blood sugar has been maintained at a very healthy level? Do we have somebody with hypertension whose blood pressure has been, regular? Those are the kind of things that we care about under the value-based care. Number two takeaway is that economic benefits are real and achievable. It is more profitable to view your billing on the value-based care approach than fee-for-service approach. Data, another key takeaway is data. Data is central to success. You must have data to be able to implement this. So you must begin to think, what actions can I take within my own facility to ensure that we are collecting the right data? Another thing is you need to start on a small scale. Just start strategically. You don't have to go overboard on all of that. Start strategically and begin to implement with time. Some hospitals have been on this journey for years and they're not still fully value-based. So it's something that you have to start small, and before you know it, depending on how big your facility is, you are able to fully go value-based. Then another thing to take away is that it's very key that you know your stakeholders and you engage your stakeholders. Stakeholder management and engagement is critical. And lastly, Africa has unique opportunities to lead in this area. I mean, it's not something that is very common around this our climb, but the opportunities are there, and it will definitely lead to better outcomes. And at the end of the day, people are able to have more get more value for their for healthcare. The doctors are better off for it. The hospital owners are more profitable. The government as a whole, because when you look at the economy, how much of the national budget is going to healthcare? How much of the national how much is the cost, or the ratio of the healthcare expense to national GDP? These are kind of different indices that are used to measure the success of this particular idea of looking at patients, prioritizing patient outcomes as against just number of volume and fees for service. So the big question: how ready is your organization to transition? From what we've discussed, from what we are looking at, how ready are you? So at this point, we're going to be opening up the mics for people. How ready was any question that you have, and we can begin to discuss what is the biggest barriers, the most promising opportunities, and any questions at all. We can take this from now. Thank you all so much.
Thank you very much, Kelechi, for that insightful conversation. Again, for those that just joined us, the topic again is the economics of value-based care, how you can transition profitably. And with Kelechi has walked us through what the difference between volume-based care and value-based care, and how critical it is for us to consider this proposition going forward within an organization. So we would like to take a few questions within the next 10 minutes. I already see 2 questions in the chat box, but please, if you have any questions, burning questions from some of the insights Kelechi has shared, please please feel free to use the raised hand button while I read the question from Chinwendu and Ibirunke. Kelechi, Chinwendu poses a very interesting question here. She says, please, how do we intensify follow-up care for patients after hospital appointments and discharge in our local facilities here in Nigeria? Then the second question is from Ibirunke, which says, you had mentioned that fee for service leads to inefficiencies. He says, isn't that a generalization? So those are the two questions we have so far. Please take a stab at them, and then we can see if other people have questions.
Okay, thank you, Chinwendu, for that question about how we can intensify follow-up care for patients after hospital appointments and discharge. First, I think I'll start with saying you must even have the data and have a like when we have the next appointment for patients, there's a calendar to track that for each patient. And then you can set up automated text messages, automated emails, automated phone call may not be necessary. We don't use letters so much in Nigeria. So I think SMS and emails will help to intensify the follow-up. And if the person does not come in to the clinic for their follow-up care, then we may not need to take a step further to give a phone call or even get to their houses. It's just that the way we do things, even our address systems, is only in maybe Lagos and Abuja. Even the Lagos, sometimes see some numbering. You're trying to look at a particular address and you are lost. So it can be challenging because I would have just said, okay, just do a letter to your people or visits. But really having set up a calendar, a schedule that, okay, these are the patients that have appointment by, because these things are routine, right? So it's all about data. You have your data, you can automate the SMS to go out on a certain date to say this person has an appointment on 20th of May. By 18th and 19th, they should be getting an SMS to say, remember your appointment by so and so time. When I was working with a doctor, I think Dr. Nirator back then in Abuja, Sunshine Clinic, for my follow-up, I usually get a message to say your appointment is in 2 days. Like, remember to keep to your appointment. And then by the time it's like 2 hours to the appointment, I also get a call to say, are you on your way and all of that. But that's a private clinic. So I don't know how much of this is going on with our public services. But really, to intensify follow-up care, you must keep a calendar. Because how do you even manage your doctors? Because these appointments are supposed to be had with doctors. So a doctor already knows that he has appointments with 10 patients. So as you're managing your doctor's calendar, you're managing the patient's appointments too. So that's another way to like follow up for the aftercare, especially when they need to like come into the hospital, or when you have to. Sometimes they don't even need to come in. Some checkups are done via phone calls, from my experience. If you don't need to, sometimes you're taught how to check your blood sugar yourself and send in the readings with a picture of the device and all of that. You send in the picture of your weight measurement, and there are different apps that make these things very simple, and they are all monitored and the data is collected in that order. So I think one thing is to have a very efficient calendar for the facility. Then we also have the other question that says, you said fee for service leads to inefficiency. Isn't that a generalization? So fee for service leads to inefficiency is in comparison. We're not saying it's totally no good can come out of it. But when you compare to value-based care, that is what we're talking about, that you see that you have more inefficiencies in that fee for service because everybody's just chasing their own number. Everybody's trying to chase how many patients or how many people came in during the day, how many lab tests did I run today. It does not matter if that test has been run before and somebody is not paying attention, because if you're value-based and you get to the lab attendant don't just blindly draw blood. I mean, you look at, because there's already an electronic data record there, and you see that, oh, this test is already carried out by a different doctor or something like that. And that kind of thing can be corrected. So it's in comparison to value-based care that we say fee-for-service leads to inefficiencies. Thank you.
Thank you very much, Kelechi, for those responses. I hope the questions have been dealt with, Iberunke and Chinwendu. Again, permit me, I'm not using our titles because I'm not really sure whether we're doctors or nurses or even consultants. So please, we'll go on a first name basis. I think there's an interesting comment from Iberunke, just follow on our question. She says, I think some facilities don't realize that their professionals are also an important resource being wasted.
Exactly.
And she gave a classic example that still having a lot of patient no-shows to specialist clinics without any compensation, especially from HMOs, gives a classic example to the point that she made. And again, just wanted
in this
to point
era
that
that we
out.
don't have enough doctors, and we are wasting the time of the few that we have.
Exactly, and you have to pay them, for the time that they are on call. So again, thanks for those two wonderful questions. If there's any other question, please feel free to put it in the chat box. But the last part of our conversation today is just to walk us through our upcoming programs. Paul, if you can progress to the first one. Now, the conversations we've had in the last hour, 30 minutes are not exhaustive, and that's why we are inviting everybody on the call to our next run of our healthcare financial management program. This is for not for finance people that are managing finance for hospitals, but if you are in a key decision making capacity for your hospital, this is a program you would like to attend. The great thing is that Kelechi also will be facilitating that session, and she will be telling us more about the value-based care, in addition to the things we've already have lined up for how you can measure your financial performance of your hospital and make strategic decisions that would impact the profitability of your organization. So we have a 10% discount for everyone who is going to register for this program today. So there's a link in the chat box for you if you are interested in enrolling for this. The next cohort will be starting on June the 6th. That's about 3 weeks from today. And you can feel free to register people from your facilities as well. The great thing is that it's easier to make transitions when you have all the decision makers hearing the same information. And so you don't have to go back and try to convince them, to make the necessary transition from the volume-based to value-based care, for instance. So please use the links in the chat box to indicate your interest, and then we'll reach out to you subsequently. The next program after the healthcare financial management program is the patient-centered care. This is also critical to some of the conversations we've had in the last hour. Because you also need your frontline clinicians to really understand the mindset, the mind shift that needs to take place within that space if you want to make that transition. And so this program will be starting on June 20th. That's about a month from today. There's also a 10% discount that applies to bulk registration. So if you're registering people more than 2 persons from your facilities, you'll be getting 10% discount off this call. And so again, feel free to reach out to us by clicking the link, and then we'll be reaching out to you subsequently. Then we have the board governance program. We've had questions from people that say, oh, do I have to be a board member to attend the board governance program? Absolutely not. If you're a management player, a management team member, you're a director in one hospital, or you see yourself as a potential director in the next maybe couple of months or years down the line, this program is for you because it gives you the mindset and the principles you need to know to be able to be an effective board member, to make strategic direction decisions for your organization. And so please register for that, for the board program as well, just to be sure that you are preparing yourself to make important transitions. And so those are the programs we have lined up for you. We decided to, on your screen right now, you can see that one of the testimonials from one of our past participants, Dr. Selman, who is a medical director from Kaduna, and she says that in the year and a half since she attended the HFM workshop, our facility has recorded 100% increase in facility treatment and what have you, and the profit margin has really increased, and we've been able to take intentional steps to minimize our losses. Again, just re-emphasizing some of the things that Kelechi talked about, that, it's not just about increasing your margins, you also need to reduce your cost to become more profitable as an organization. Secondly, I can now pick out accounting errors, even as a non-finance person, which is very important. You can be in a room.
Happy for this feedback, really.
Yeah, you can be in a room filled with accountants and finance people giving you updates on what's going on as far as the healthcare, the financial performance of your organization, and you're not making sense of it. So this program goes beyond just the financial components of your organization, but helping you with the tools and the tricks you need to make sense of financial information, gleaning insights from all of those. So please feel free to register for the program. As I said earlier, in 3 weeks' time, we'll be having the next run, and Kelechi will be helping us make sense of all of those financial jargons that our finance people put out to us, and more importantly, make strategic decisions that impact on our long-term profitability and sustainability going forward. I saw Dr. Kaine Delta speak at some point. I don't know if she's still on the call. Dr. Kaine, it's good to have you on the call. Do you have any question or comments or contribution for us today? How are you doing? It's good to see you.
I'm doing great. Thank you, Dayo, and good evening, everyone.
Good evening.
Thank you, Kelechi. Yeah, really very interesting perspective, value-based healthcare. When I saw the topic, I didn't really have an idea what it was about. I just joined in, and I really enjoyed it. So looking at fee-for-service versus the other models you talked about, especially the bundled payments, it was just interesting to see the contrast, and then the fact that the value-based healthcare is mainly outcome-based. But someone has dropped a question in the chat about the providers, and in Nigeria particularly, so fee-for-service really, and then out-of-pocket payments from private patients seems most times to be better, because people have to wait for HMO payments and all that. And it's really, 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 it could be frustrating, So I just look at how soon, we can imbibe the value-based healthcare. Then another aspect of it, which is interesting, is the emphasis on preventive healthcare. That will really be good, and that would be a starting point to actually drive the value-based healthcare. I think there's a lot that we can do in the healthcare space for our preventive healthcare. But then again,
absolutely.
The preventive healthcare should be evidence-based. What we have, everywhere is, through a barrage of investigations, and people just carry out a basket full of, investigations that are really not necessary. So again, that would not be value-based, it would just be, yes, something different. So yeah, certain points are preventive healthcare, but evidence-based will really help to push the value-based healthcare. Thank you again, Kelechi. I really enjoyed the conversation.
Thank you very much, Dr. Kaine. And yes, that comment was from, I think it's a Dr. Jide, or like just Jide, I'm not sure it was a doctor, but Jide Fadikpe said that in Nigeria, fee-for-service and private patient revenue are more like sustainable for hospitals than relying on HMO. So when we talk about value-based care, even your private patients can be billed on that level. Now, you don't have to, what if you're dealing with a private patient who like is diabetic, for instance, and we have like, okay, this person is on a monthly drug, on checkup, on some routine checks and everything. And then you just arrange the bill and say your monthly bill is this amount. One is that you have a sure cash flow. Like once you lock in that kind of contracts with those out-of-pocket patients, and they're able to see value instead of saying, okay, do I come for my checkup? Do I not come? They've paid once, right? And this is for they understand, they trust that this is for their own good. So they don't have to miss their appointments because they don't have money. There's already a contract to ensure that they are well, and the target is to ensure that their HbA1c is kept at a healthy level. You explain that to them, then they begin to pay you out of pocket, but on a value on that bundle package where, look, we are managing your diabetes. This is the monthly cost. We are managing your hypertension. This is a monthly bill to manage hypertension. What that helps you do also with data is that you know how many hypertensive patients you're handling, you know how many diabetes patients you're handling. You already have a funnel to track your cash flow. You know how much you expect on a monthly basis and all of that. So you can do that with private patients. Now, I've already said that we should start small. So what that means is that we can't start having that conversation with the HMOs. But of course, until we have that contract, we cannot begin to build HMOs on bundle basis. There must be an agreement. And like I said, you'll be surprised how many HMOs are happy to go on this kind of arrangement. So it's all about starting those discussions, trying to have those kind of contracts. And for your individuals, you can still bill on that bundle basis. You can say, okay, from antenatal to delivery is 1 million naira. And that is it, from this to this. So irrespective of whether it's going to be a CS delivery or vaginal birth, what we are concerned about is what is the best for the mother and child. And everybody can just have peace, and you're able to do your job. Nobody's owing anybody, and both the patient and the doctors are happy. Thank you.
Fantastic. Fantastic. Any final comments from the floor before we wrap this up for today? Okay, I don't see any other comments. On that note, we wanted to thank you, and thanks again, Kelechi, for your time with us. We know that it's always a pleasure to have you here. We're looking forward to having you for the HFM, the next cohort of the HFM that's starting on the 6th of June. And we hope that people on this call will be also attending that session as well. Please, if you have any questions. Oh, I see Dr. Lape Mobology also is in the house. She attended one of our board programs that we had sometime in 2023, I believe. Hi, Dr. Lape. Hope you're doing great today.
Hello, Dio. Good evening. I'm not a doctor. I keep reminding you.
Oh, yeah, absolutely. Yeah. Thank you.
Yeah,
Thank
but
you.
good evening, and thank you
Good
for
evening.
the webinar. Thank you, Kelechi. Very, very, very well done, as always. Thank you.
Thank you. So thanks again for joining us today. We hope to connect with you anytime soon, particularly on the 6th of June, as we take this to the next level. Between now and then, we'll be sending you the recording from the session today. And if you have any questions whatsoever, please feel free to ask us, and we'll be more than happy to respond to that. The WhatsApp group are usually open 24 hours, 7 days a week. If you have questions, just put it there. We would respond to them when we can. And you can also shoot us an email at info@hleafrica.org. So please feel free to reach out to us through all our channels, and we'll be in touch with you. Thank you once again, and enjoy the rest of your day and the rest of your weekend. On behalf of myself, Kelechi, and the rest of the HLA team, we say thank you again for joining us. And till the next time, do well to be in touch with us. Bye for now.
Thank you all.
Thank you.
Thank you.
Bye-bye.
Bye.